Welcome and thank you for joining us. The American Society of Transplantation is proud to present today's webinar on an overview of the current financial ecosystem of organ donation and transplantation. This webinar is an AST Controversies Conference work product and co-sponsored by the Transplant Administration and Quality Management and the Donation and Transplantation Optimization Communities of Practice. In a moment, I will turn the session over to our speakers, Ms. Jennifer Milton and Ms. Dara Washburn. Before we begin the main presentation, we have a few housekeeping notes to help you engage in today's session. There is currently a poll on your screen displayed for the audience. Please take a moment to answer this question while we finish the remaining announcements. This webinar is being recorded and the archive will be available on the AST YouTube channel 2 to 3 business days from today. Please note that your lines have been muted so that only the presenters can be heard clearly for the archive recording. If you have a question for our panelists during the webinar, we encourage you to participate by using the Q&A button in the Zoom webinar panel. Questions submitted via the chat window may be missed during the presentation. Finally, when you log off at the conclusion of today's webinar, you will see a link to a short evaluation survey to complete. Please fill out this survey to help us keep our content current and engaging. I will now turn today's session over to our presenters, Ms. Washburn and Ms. Milton, to begin the presentation. At the conclusion of the presentation, Ms. Andrea Tietjen and Alexandra Glazier will join to moderate the Q&A session.
Thank you so much for the warm introduction. I'm going to start by introducing myself. I'm Jennifer Milton. I'm the Chief Administrator of the University Health Transplant Institute in San Antonio, Texas. And my co-presenter, Dara, if you'd like to introduce yourself.
Yep, sure. My name is Dara Washburn. I'm the Chief Financial Officer at New England Donor Services, and we operate the OPO in Region 1.
I wanted to share, Dara has no relevant disclosures, and I entered a consultant role with an organization in the last 24 months. What we hope to cover today, and I put the emphasis on the title of current, is to really talk about the recent Medicare proposals, how reviewing briefly the financial models, both of transplant centers, which I'll cover, and OPOs, which my partner, Ms. Washburn, will cover, and highlight for you some of the impact and unintended consequences of those proposed changes. And we hope that we end you with a strong call to action. I did want to highlight and welcome you that we are giving this lecture during Donate Life Month, an opportunity for the whole country to spread awareness of the need for organ and tissue donation, the success of transplantation. So to talk about the current proposals that are really shaping and why we are presenting this topic to you today, it's really give you an overview of current proposals proposed by the Centers for Medicare and Medicaid Services that would fundamentally change how transplant center finances work and OPO finances. This began with an inpatient prospective payment system proposal that was launched in 2021, where Medicare proposed a radical change to how transplant center and OPO finances worked, which we'll delve into a little bit later. And then shortly after that, just a year later, Medicare proposed essentially a revision of that proposal, but interestingly in the hospital outpatient prospective payment system. And I know a lot of you watching are not transplant or OPO administrators, and you may not understand deeply the finances of transplant, but I will just point out that no one in transplantation or the OPO world focuses on the hospital, on the HOPS, the hospital outpatient prospective payment system. We've always focused on the IPPS. So we were pretty shocked when this came out in the HOPPS, and it tipped us off that maybe there was some urgency at Medicare to release a revised proposal. And we'll cover that later, but those are the types of, those are the setting in which, and the proposal that we're going to cover as we move on today. What I can tell you and how I summarize this before we get to our objectives is when we really step back and look at the big picture, why Medicare was proposing these changes is Medicare has unequivocally, Centers for Medicare and Medicaid Services have unequivocally said that the private payers that fund transplant events in the United States Medicare does not feel they are paying their fair share of the cost of transplantation and donation. Interestingly, I sort of refer to it in our exposure in meeting with CMS, HRSA, and all of our organizations was that on the right hand of Medicare, that is the financial work group within Medicare, and their focus is a solvency, understandably, of Medicare. But on the left hand, and the world, most of you watching today, and those of us presenting today, Medicare is really focused on initiatives to increase access to transplant more organs that are not being used right now. And I think you're following those policies very closely. That right and left hand not being on the same page influenced the development of a group, the Organ Transplant Affinity Group, where Medicare listened to the stakeholders and HRSA collaborated to bring all of the regulatory arms together to make sure all of the regulations and proposals had aligned incentives. And so I encourage you, we're not going to cover OTAG today, but look that up and be engaged with that. So I think the other thing is just that big picture of what are we doing to get engaged. So I'm going to cut right to the chase and tell you that last proposal and the FY22 HOPPS, the results of that were modeled. We pulled Bridget Sullivan, a tremendous colleague, pulled every filed transplant center cost report in the United States. This is actual data, and I know you're probably leaning in your screen to see it. Did an analysis removing the donor organs, which are currently counted as part of a transplant center's OAC, and I'll show you the math in that in a minute, and showed conclusively that there would be a $380 million loss to transplant centers. And I'll cover where that money comes from and what we're doing about it. But I wanted to cut right to the chase and say, here's the bottom line. CMS sees an opportunity to save $380 million from their budget. Transplant centers and OPOs see that that would devastate our current high stakes environment and high performing environment. So let's dive into some of those details. I said we were going to kick off and talk a little bit about transplant center finances, and I'm trying to go as fast as I can to get through that. But essentially, this in your mind should be what you hear your transplant administrators often call the Medicare cost report. Medicare cost report reimburses transplant centers for money spent, reimbursed, not paid. They reimburse you for the dollars your transplant center has spent on pre-transplant, getting patients and getting organs to patients who are on the waiting list. I'm not going to go into great detail of that, but that includes all of your pre-transplant staff, including those pre-transplant expenses, including the cost of the organs, the flights to get the organs, normothermic perfusion, and staff. And in short, Medicare allows you to take all of those costs, whether you charged a private payer or you charged Medicare. You multiply it by the ratio that I have in brackets there, and that ratio is how many traditional Medicare organs, extra-renal, or Medicare Advantage and traditional renal organs of all the transplants you did. And importantly, the Medicare organ count includes currently that donor organs procured at a hospital that also performs transplant also count as a Medicare organ. You have to subtract any monies the OPO pays you for the care of organ donors in your facility, and that gets to your cost report reimbursement. I'm again not going to go through a lot of details on this, but here's just a brief summary to show you. In this one hospital, they spent $4 million in all three scenarios on the cost to get patients on the waiting list and acquire organs. The only thing that has changed in all three scenarios is in scenario 1 versus 3. This same transplant hospital, their great efforts at the hospital resulted in 2 livers being donated and transplanted elsewhere. And in scenario 3, 12 livers were recovered and donated and transplanted elsewhere. And if you look all the way at the bottom line, financial impact, you can see the revenue impact for that transplant center, the increased portion of the reimbursement they can receive because of that mild increase in organ donors. And that will give you a clue as to how that $380 million loss to the transplant centers was determined. The other thing that's really critical to understand about transplant finances is that, of course, these are pass-through paid at cost. but also to understand that those other payers Medicare is counting on to pick up that $380 million are essentially about the same 6 companies. I always tell people to Google who are the leading companies providing managed Medicare, managed Medicaid, ACA, and employer group health plans. And what you will see is about the same 6 companies continue to occur. So the concern is that all $380 million of that loss, we would have to pass on essentially to 6 companies through the administration of these different products. I always like to show this slide and say, we aren't counting lives in dollars and cents only. We know that increasing access to transplant is priceless. So Dara, I'm going to turn it over to you and let you cover OPO financial model.
Great, thanks, Jennifer. So I just have a couple slides to give you some context around the OPO financial model, if that's not something you're terribly familiar with. All OPOs receive Medicare reimbursement through a cost reimbursement model with CMS or Medicare for the costs related to renal costs. OPOs also have other revenue sources from the non-renal organ charges. Most OPOs do tissue recovery and fundraising, other 2 categories that kind of supplement the revenue sources. On the expense side, the categories we typically see are direct expenses, overhead, and administrative expenses. Just to give you, can you go back 1 slide, Jennifer?
Sorry about that.
Yeah, that's okay. The main revenue source that OPOs have are organ acquisition charges, and those are the fees that OPOs charge to transplant centers or other OPOs for both renal and non-renal organs that are transplanted. And so CMS currently approves any changes to the renal OACs. And on the other side, transplant centers reimburse OPOs for the costs in reimbursing or paying the charge of the organ acquisition costs. Just want to make note, OPOs do not bill insurance. That is handled on the transplant center side, as Jennifer indicated earlier. On the reimbursement or the cost report, OPOs also complete a cost report. Currently, OPOs receive 100% reimbursement for costs identified as renal or kidney related on their cost report. The organ acquisition charges that are billed to the transplant centers during the year, these act as an interim payment to ensure proper cash flow for the OPO. And then OPOs reconcile with CMS at the end of each calendar year in a cost report, which results in a settlement amount either due to the OPO or paid to Medicare. On the expense side, obviously every organ donor in recovery has its own set of circumstances. Typically, the expenses that an OPO incurs during the recovery of an organ or organs from an organ donor are listed here. In addition to the direct recovery costs like donor hospital reimbursements, surgical recovery, the OPO also has overhead and administrative costs, salary costs that are allocated between both the renal and the non-renal cost centers on the cost report. The OPO files cost report 21694 and using Medicare's required cost allocation methodologies, basically the cost report results in costs for renal and non-renal and tissue activity, and the computation of Medicare share currently is 100%. And so the cost report calculates the costs for kidney recovery, and the charges that are billed during the course of the year are offset, and then a settlement amount results either to the OPO, or if the amount of the organ acquisition charges were higher than what the kidney cost was during the year, the OPO would make a payment to CMS. You can skip one ahead, yeah. So just on a high level, the key financial drivers for OPOs are really the percent of renal and non-renal activity, organs recovered. The service model that transplant centers have with their OPO really varies region to region, especially with the changes that we've seen to broader distribution over the last several years. So that model is important, and it's variable between the 56 OPOs. The cost report, which I talked about before, and then if the OPO does do tissue recovery, that obviously is a very key financial component of the OPO financial model. And just to reiterate, the kidney activity, OPOs cannot generate any margin on kidney activity, and just because of the nature of the cost reimbursement model. So Jennifer talked earlier about some recent rulemaking. The rulemaking that has been finalized over the past or within the last 2 years really hasn't made much substantive change to or had significant financial impact to the OPOs up until this point. The rule that was finalized effective in 22 made a change to how OPOs charge for non-renal organs. Prior to this rule, many OPOs had the model of doing add-on charges to the organ acquisition charge for transportation, whether the organ was imported or exported. And so all OPOs must have a standard model for charging for both renal and non-renal, meaning one amount per organ that they charge the transplant center or the OPO. Also a requirement for hospitals to bill the OPO for services furnished during the course of an organ recovery at its charges reduced to cost. And that was obviously a saver for Medicare. They obviously wanted to reduce their exposure to hospitals that were billing OPOs high charges for the cost for the services rendered at the donor hospital. You can go to the next one. And then the other rule that was finalized in 2023 made some changes, just clarity on how OPOs count organs on the cost report, and then certain hospital services that were, not allowable are now allowable for potential organ donors. But the two proposals that we'll spend time talking about today were included in the final rule, but ultimately not finalized from Medicare's perspective. The counting policy for how OPOs and transplant centers count donors and organs on the cost report. And then for OPOs specifically, changed to CMS's reconciliation on the cost report. And those two were not finalized, but both would have significant financial impact for OPOs. When we saw the proposals that CMS had on the table, we recognized immediately that these were very complex and needed real proactive advocacy as a field with CMS. And so earlier this year, CMS invited a stakeholder group to Baltimore to meet with them to, kind of hash through some of the concerns that the groups had. That group included AOPO, AST, and you can see the other groups that were included there. So we saw this as a first step to really having dialogue with CMS about this. And so the change for OPOs with regard to the first item that was not finalized was how organs are counted on the cost report. And, Medicare is committed, as Jennifer, said, to keep the Medicare fund solvent and is looking for ways to reduce their reimbursement or share of the costs. And so for OPOs, have indicated that they would only reimburse for organs transplanted into Medicare beneficiaries. And so, as I mentioned before, currently OPOs receive 100% or are able to count 100% of the kidneys transplanted towards their Medicare share. And this would change to only limit that only to transplants that are made into Medicare beneficiaries. So as you might expect, this would provide for significant reduction in reimbursement to OPOs and would really change the OPO financial model, just given that OPOs currently don't have access to the payers of the recipients receiving the organs. And so we're not really able to do an accurate financial planning or modeling to determine currently what this means for OPOs. OPOs do not have access to the recipient information. And so, as I said, this would be something that we would have to establish access to and be able to have the information to properly project any financial impact. The difficulty with Medicare's proposal, more specifically, as it relates to the changes that we've seen in organ allocation policy over the last several years. Prior to these changes, most of the organs recovered in at OPO's DSA stayed in the DSA for transplant, and that model has really shifted, especially for the OPO's business model. As you all probably are aware, organs are recovered and transplanted across DSAs now. This has increased the administrative burden of tracking all of that for the OPO. You can go to the next slide. And so tracking the recipient information within this model of broader distribution really creates a very complex situation for OPOs. And the example I have here just illustrates that if there was a donor in Region 1 where 2 kidneys were recovered, one of those kidneys transplanted in Region 9, the other in Region 2, the OPO in Region 1 would have to obtain the recipient's insurance status for both of those patients to determine how to count organs on their cost report. And we currently do not have access to this information. So our recommendation to CMS is that if they are committed to moving forward with this type of change, that they would need to develop an infrastructure for OPO access in real time to payer data and verification. Maybe using a centralized database where recipient payer information would be maintained in real time for accuracy. And we also asked CMS for a timeline for a collaboration and testing and confirmation that OPOs would be able to get this accurate information in order to determine how they counted organs on the cost report. The other change or proposal that CMS would like to make is to have cost reconciliation or settlement for all organs, non-renal organs and renal organs. This is problematic for many reasons, but as OPOs are not able to generate any margin on kidney activity, actually most incur losses for the work and the costs related to renal activity, because there are not lots of costs that OPOs incur that are not allowable or not reimbursable from a CMS perspective. So currently, those costs are offset by the other organ cost centers and then any tissue activity. And so the cost reconciliation process for all organs would create a cost reimbursable system for all really of the OPO's organ activity. And at a time when OPOs are making significant investment in growth, certainly under pressure to innovate in how organs are being recovered, this would be problematic for OPOs. It would really provide, really unnecessary financial uncertainty in our budgeting, in our planning. And at this time, given all of the things that our OPO is investing in, it would really limit our availability or sustainability. The other situation that this proposal would create would be a Medicare and non-Medicare organ acquisition charge. So the OPO could set those at different amounts depending upon the counts on the cost report. So for example, if there was a Medicare recipient, kidney or liver, that would be assigned the Medicare rate. And if another payer the recipient had a different payer that was not Medicare, that the OPO could charge at a different amount to that payer, perhaps higher. We would certainly expect that to be higher than the Medicare rate in order for the OPO to maintain its financial sustainability. We think this would really create an administrative burden and would divert resources from our core mission, having to create these new financial models within each OPO to comply with these final rules. And then just lastly, as I've kind of indicated throughout the slides, we don't feel that these proposals will be sustainable for OPOs financially. They certainly seem in conflict with the new CMS metrics and HHS's goals to increase the number of organs available for transplant at a time when OPOs need to be properly resourced for innovation, investment, and growth. The time for this proposal is certainly challenging and really threatens the financial stability of our system.
Thanks, Dara. I'm going to shift gears and sort of highlight, I think, or capture sort of overall impact of Medicare's modified changes. You'll see a moderate change in the background of our slide, and I'm really proud to share with you that Dara, myself, and our two moderators today all were with Medicare in that meeting Dara referred to on January 25th stakeholders meeting. And these are the content that we wanted to be really open and share with our entire community of really being persuasive, we feel, with Medicare on these of the financial impact and the unintended consequences of moving ahead. We really highlighted again, just in this slide, again, we calculated the loss to the 262 transplant centers in the US, which is only 4% of all of the hospitals in the US. And it was only because with 2022 data, only half of the transplant center cost reports are available for 2023, but all of us are living in the environment where we know costs of organs, cost of transporting them, and cost of perfusing them are skyrocketing. So certainly by 2023, when we're able to complete that analysis, we will see that the impact was substantially higher than $380 million. And so we really stressed to Medicare, as you can see in the slide, can there be compensation for this loss of $380 million or more dollars? Is this the time to do it? We explained, as I pointed out before, it's all the same payers. That we highlighted that although they're the Centers for Medicaid and Medicare Services, Medicaids are state-based, and there are many state systems that do not reimburse at all for the cost of organ for living donation and have exceedingly low DRGs. And that those 6 large private companies are often contracted on multi-year contracts that would require a actual cessation of the contract prior to renegotiation. So if Medicare just moves ahead, every one of our 262 transplant centers, knowing we are contracted with the same 6 companies, would essentially have to stop our contracts at the same time, totally devastating the national waiting list and inactivating those patients until such time we should get through those contracts. Our only point in that was not to alarm you or not to alarm them, but to say this has to be cautiously approached with the private payers at the table as a stakeholder to understand what they're going to do and how they're going to respond. We highlighted to Medicare something that all of you watching, I think, already know. Transplantation is a huge saving on the burden of ESRD patients, a population and a burden that continues to grow. And that, in fact, by making this payment shift, if it reduces access to kidney transplant, any savings Medicare may realize in the short run could be dwarfed by actually a growing number of ESRD patients waiting even longer on dialysis. We highlighted again, the timing may not be right now. We continue to be in a crisis with the number of people being added to the waiting list outstripping the number being removed for various reasons. And we stressed all of those pressures from the left hand of CMS to increase access, all that our community is doing through other work groups to increase access would really thwart our utilization of those organs that are currently at risk, because we count on and we need the Medicare cost report to help offset those costs right now. We pointed out the NASM report, another RFI where Medicare was seeking information on reducing discard. We talked about the work of the Expeditious Task Force. We talked about the negative media and public attention of Senate Finance and others on all of our communities need to increase the use of these organs, where this payment policy shift at this time would completely fly in the face and exacerbate and not allow us to carry through on those regulatory goals that are currently occurring. We talked again about, we really stressed what a transition our ecosystem is in. The allocation changes that Dara already highlighted, with continuous distribution continuing to become more continuous, the modernization effort that's underway, and then just what is happening with the increased cost of organs, of course. So to throw in another massive change to a policy on reimbursement that has been in place for over 3 decades, was a foundational payment policy our entire community was built upon right now, with all of the other transitions happening, our ecosystem, would it really devastate our community and not allow the government and the regulators to realize the visions they have for improving organ donation and transplantation? We highlighted what we felt we stressed to Medicare, our professional societies, that they had the power to shift these unintended consequences to anticipated and ones that we could all collaborate on and work on a pathway together. What would the impact be on the currently high rate of organs that are non-used? What would be the impact on the sharp rise, 40% increase in DCD donation in only the last 3 years? It's now 36% of the country's entire deceased donor population. What would be the impact if transplant centers and OPOs couldn't better account for those costs and being reimbursed for those costs? Children's hospitals are particularly concerned because of their heavy reliance and heavy funding of Medicaid, which I mentioned before. And certainly, as called on the NASM report, we have seen about a 300% increase in the opening of dedicated donor care units with great success. And it's unknown how the country will continue that innovation and improvement if this modification were to occur without, again, making these consequences anticipated. I'm not going to go over our broader questions. I think we covered those earlier. But what we call the Medicare to do, again, know and anticipate the consequences, study those, bring in all the stakeholders, and make sure they're continually engaged in part of the dialogue. So before we get to a Q&A, I hope Dara and I weren't too fast for you in covering a lot of content. If you're watching this and you're asking yourself, okay, whoa, what am I supposed to do? We're going to give you two sort of recaps of that. The first big call to action is email your government relations person right now or your leadership and say, are we watching these changes Medicare is proposing? And just track and follow those for future publications or revisions. Get engaged with OTAG, the Organ Transplant Affinity Group, and your payers to understand any strategies they might have for cost containment. When these public policies are released, you need to put pen to paper, your organization, and submit a public comment, even if that public comment is, we're worried, we don't know how we're going to recoup these costs, we need more time to it, and more engagement and understanding these consequences. Now, I can't leave this slide on Donate Life Month and partnering with a great OPO finance leader without telling you, if you saw my analogy earlier, the single most important thing you should be doing right now is improving deceased organ donation at your hospital. Call your OPO, a simple call. Ask them, hey, what do you need at my hospital? How can I help you improve donation? Make sure your transplant members are actively involved in your hospital's donation PI team. Serve as a liaison to help your OPO, any doors you can open with neurosurgery, neurology, emergency center, and on. Work on your policies, drive your hospital to investigate failures to honor first person event, failures to follow your own policy to refer donors in a timely manner, to trigger those as thorough reviews or adverse events. So again, I showcase to you a moderate increase in organ donation improves the reimbursement to your hospital. That's how the reimbursement was structured in 1970s to incentivize hospitals and OPOs to increase donors available and access to transplant. We argued those policies have been incredibly successful. 13 years of record-breaking organ donations year after year, and 13 years of transplants increasing year after year. So we'll turn it over to questions now, but thank you so much.
Thank you, Jen and Dara. I really appreciate you summarizing. There's a few questions out there, so I'll go ahead and get started. The first question is, with CMS's proposed change of organ counting to shift cost to private payers, how would recovered but unused kidneys and probably more importantly, extrarenal organs with potential Medicare recipients be counted, both for the OPO and the organ recovery surgical team?
Yeah, I can answer that.
Good.
on the OPOs. The OPO currently on our cost report, we don't count organs that are discarded or not used. The reimbursement model is based upon the organs that are ultimately transplanted. However, CMS has not, at least to my knowledge, proposed changing the OPO's count of those organs towards cost allocation. So the OPO currently uses those statistics that include organs that are not recovered. We use those to count cost towards the renal and non-renal cost centers. And so it's not my understanding that they're proposing that to change, but only the change be made to the resulting transplanted kidneys.
So before we go any further with more questions, just a comment to that, all of this work originated with the Controversies Conference, which was about 18 months ago. And really, frankly, even since then, so much has changed. And these topics are so timely and important to trying to support all the work that we're doing. And thinking about the proposals and the conversations you're having with CMS, have they provided a timeline on when some of these proposals may be finalized, and are they mindful of all of the other major structural changes that are happening in the donation transplant ecosystem at the same time?
At the stakeholder meeting that we had in January in Baltimore, they indicated they wouldn't be making any changes or proposing any further rulemaking this year, and that they would continue meeting with us, establishing dialogue, and then really revisit this in the next year in 2025. And the first year impact would be in 2026. They are very mindful of all of the changes that are currently going on in organ donation and transplant. At least that was communicated to us in a way that we felt they understood that.
Okay, although 2026 is a year where there might be, very substantial changes in the field of OPOs, and having the possibility of major shifts in financial models at the same time seems like, ill-advised, too much change all at once, but it sounds like they're listening. Question mark?
Yep. No, I got the impression they are very aware of all the changes with the performance metrics and the dates that are applied to those. So my impression, and Jennifer can speak as well, was that they were understanding of that and how chaotic it would be.
I'll just add a huge shout out to our professional societies that Dara sort of listed all the acronyms for. On behalf of you, the members of the community, they are watching these policies intently. They're engaging the leaders of OPOs and transplant centers and other associations to monitor these closely. Again, I'll come back to my analogy at the beginning of the right hand and the left hand. I would say that the great thing our professional societies did was invite the right hand to the table so that the policy development of HRSA and CMS were at that stakeholders meeting, listening to the conversation with the financial group redesigning these components. So I think that our peer society brought the arms of Medicare together and engaged HRSA to really marry those unintended consequences to the goal of solvency.
And I would just add that I think one of the most important outputs of that first meeting was that we've established a collaborative relationship, and they recognize the knowledge gap that they have, and they're very willing to reach out to the content experts and really educate themselves before they move forward and really formulate any proposed changes.
Jennifer, you were, I think, starting to type an answer, but it might be beneficial for you to give a verbal answer to a question that was submitted. Would the change in Medicare organ share only impact OPO cost reports, or would this also impact the way transplant centers count their Medicare organs?
Well, I was relieved when I saw that question was posted at 1:35, was about the time Dara handed over the baton to me, and I hope I was able to highlight the steep, critically crippling impact to transplant centers. We have a spreadsheet that models the actual loss to every transplant center in the country. But you can simply call your cost report person, tell them to remove donor organs from the equation, and they can tell you what yours currently is. Devastating to our patients on the waiting list, those who want to get on the waiting list.
I have another question for Jennifer. What is the community doing to engage the private payers? I think that they're clearly very involved in the potential solution to this change.
So a great development is serendipitously the Transplant Administrators Committee kind of rebirthed or revived payers group, payers relation group that had been in the past. Those collaboration had developed, if you're a transplant administrator, the RFI, and really made other gains that benefited the whole community. So through that forum, I was invited to speak and gave a presentation to the payers. It was well attended. Again, you know, we are reinsured business, so largely our patients are managed by only 6 companies, no matter the product, as I highlighted earlier. We really gave that group of payers a call to action. We got a lot of follow-up interest, and I'm very happy to say many of those payers attended that entire day's stakeholder meeting to listen in. It did not appear to me that the payers were following this policy and understood the impact until the Transplant Administrators Committee really raised that bar. So we've called on the payers because we think it's critically important to understand how they will respond if in fact they have to turn around and pay almost $400 million more for the exact same number of transplants, mind you. How will the payers respond? And if you're a transplant administrator, or Andrea, you, I know in administering transplant centers, you know that some transplant payers do things like crazy lifetime caps. We'll give you $150,000, but the patient's lifetime maximum for all transplant care is $200,000. Well, if that's how payers respond for cost containment, or payers even further restrict their criteria to not pay for the highest risk transplants, we don't really know what their strategies will be to cost contain, because they will certainly have to cost contain. Many payers will say right now, transplant is almost outpricing itself for the volume of patients that need it, for the cost of what the payers are paying. So of course, we really wanted to engage them to understand what are their cost mitigation strategies, how will it impact our patients on the waiting list, or those we want to give even greater access to. So at least I'll say in short, they're engaged.
All right, we've got another good question here. What are the current incentives and disincentives to a transplant program who's actively managing a donor to transfer that donor to an OPO based on a donor recovery center or DCU? Doesn't that reduce the Medicare share for the transplant center? And if so, how can this be reconciled so the benefits of a DCU are optimized, but not at the expense of a transplant center? It's a great question, and certainly one I know that the OPO community has been talking about as well.
Yeah, I think it's a fantastic question, and a reality for every one of those donor care centers, transplant centers, and OPO. All of our community as donor care centers of RISE. Every sector of our community is facing this question. I will say it's a valid question. We're having that internal discussion to try to understand what can we as a community propose as a solution to this, so the government isn't developing the solution and telling us what to do. 2, I think we have to be mindful that the costs to manage the donor are then borne by the donor care center, no matter the construct of the donor care center, freestanding or hospital-based. So what is that fair split? And I would say to the transplant centers that get to transfer their donor, that are face that dilemma of transferring a donor decreases their Medicare ratio and therefore decreases their reimbursement. I would say to that transplant center, you need to showcase all that you are doing to invest your current revenue from Medicare in enhancing and maximizing deceased donor organs at your hospital. So one of the reasons donor care centers, for example, are so successful is access to the OR. One of the reasons OPOs want to move donors to dedicated donor care centers is unlimited access. So if you're a transplant center really pushing to keep that donor, it's fine, but resolve the OPO's operational issues and their lack of access to experts, OR rooms, and the consultants that they need. Make sure your own hospital, your own transplant hospital, is performing at as high a level as a donor care unit. I think that's a good starting point for the more difficult conversation ahead.
Yeah, and I know there's also been some advocacy efforts to try and address this, to see if there's a way to ensure that the reimbursement remains even if there is a transfer, so that the count is not disturbed for the transplant center if the donor is in fact transferred to a DCU. And those efforts are ongoing and collaborative between OPOs and transplant center hospitals as well. But, you know, we'll see how open CMS is to that kind of perspective. Okay, I think we've got some other questions here as well. Where can we learn about the proposed changes in the outpatient transplant patient care? So where can people find more information?
I see that's from the great Kevin Fowler. Thanks for that question. I would say, and most people consider outpatient transplant care, most people consider that post-transplant care in a nanosecond, just looking at it, other than just a devastating financial loss for your transplant center and how that impacts your ambulatory care. There was nothing specific to this that related to post-transplant care, because for Medicare and payers, that's typically fee for service, right? This was really focusing on the Medicare Part A, and Medicare Part A is where we submit our cost report. And of course, some ambulatory pre-transplant costs are counted there, but by and large, it focuses on revisions that impact Part A, which is where the transplant centers submit their cost reports.
Thank you. Dr. Kumar was just asking what was the previous Medicare ratio and what is the new change? I think thankfully, based on Jen's last slide, is that through a lot of advocacy and proactive education, there have not been any changes. And we have really been invited to collaboratively work towards mutually beneficial solutions so that we can continue to expand transplantation and donation, as well as not inhibit some of the growth that might occur with this reduction in cost. So thankfully, there has been no change to the Medicare cost ratio at this time. And we are hopeful that with these continued meetings and discussions with the OTAG, that we can be a partner at the table and help to come up with these solutions together.
And Dr. Kumar, I would just kind of summarize again, the Medicare ratio is the number of Medicare organs you do. For liver, that includes, for extra renal, that's traditional Medicare organs. For renal, that's Medicare Advantage plus traditional Medicares, divided by the total number of organs you transplanted. So in some of the scenarios, I had 60 liver transplants, 40 had traditional Medicare. That would be 67%. For all of your expenses, you would be reimbursed 67%. But if your transplant center was also a hospital where 2 people donated their liver, or 10, instead of that would be added to that 40. So you go from 40 to 42 to 44, and your ratio would not be 67%, it would be 70, 75. And then you get a higher reimbursement of the dollars you were already spending. And Medicare has proposed removing the donor organ from being counted at all in that ratio. It's not passed, as Andrea highlighted, though.
Thanks, Jen. There's another question, and this is interesting because I think we've gotten this before. Is there any thought to if hospital OPOs will be asked to change the way organs are counted for the purpose of the transplant program's Medicare cost ratio? Currently, we are able to count all organs recovered in the DSA, not just those at our hospital.
I see Melissa in Wisconsin asked that question. Melissa, I'll just tell you, when we began to introduce the topic of hospital-based OPOs, and Dara, you weigh in on this, I will tell you, it really confounded the financial Medicare experts, and it almost distracted from just a complete re-education and re-education and re-education of the very fundamental building blocks. We'd love to see a hospital-based OPO really more at the table, really advocating for how this will impact you. But right now, I would say Medicare really doesn't have that education. And as that number is so low, I don't think in the discussion, it's been the priority. The priority has been to stall while that analysis could occur, and to include the looking into hospital-based OPOs as part of that analysis.
Question, switching gears a little bit, the 2022 change really impacted transportation and how OPOs could or no longer could pass through air transportation, for example, as a separate charge, but had to include it in its cost overall in a singular OAC. Can you comment on how that's impacted OPO financial models in regard to ex vivo device use?
Yeah, I can answer that one. So as Alex indicated, and I indicated in the slides, CMS mandated that we OPOs set one organ acquisition charge per organ, where prior to that, OPOs really had a lot of flexibility of how they pass through those high cost items that are indicated, like air transportation, the ex vivo devices. Those things could be added on to the organ acquisition charge and really billed directly to the transplant center that was using them, use the flight or use the device. But with the change, OPOs are now required to include those costs if they are bearing them into the organ acquisition charge that they bill the transplant center. But that charge is the same to each recipient or each receiving transplant center, even if they didn't use that particular air charter plane or the device for the transplant. And so the impact of the change is that all of those costs have to be included in that charge. And so the impact could be to a transplant center that didn't use the device. They're bearing a higher cost for that organ than they would have previously. So it's really spreading those costs that the OPO incurs to all centers or receiving transplant centers to bear those costs. Now, models are variable in different regions, meaning that some transplant centers bear the cost for air transportation and the ex vivo devices directly with the vendors providing that service. But that is not a consistent model nationally. So it really varies on the region. But certainly certain centers would be paying more for perhaps services that they weren't, that they weren't having.
So, I mean, essentially it's a, it depends kind of answer, which as an attorney, I always appreciate. But I think what it's doing is it's providing incentives for models that where instead of having the OPO kind of orchestrate all of these extra components, it's incentivizing and pushing it out to the transplant programs so that they're paying for their own use rather than it being spread as a cost throughout all of the OPO's activity. And
Yep,
we've
that's correct.
seen that in our region as well. I have another question here, I think for Jennifer, which is pediatric hospitals. We saw it sort of flash on a slide that they might be particularly impacted. Can you unpack that a little bit more?
Sure. It really critically ties to the difference in the payer mix and the payers that are funding pediatric transplantation. You have to think kind of on a big national view that the majority of pediatric transplants are happening in those large pediatric transplant centers that are also academic institutions or trauma centers for the care of pediatrics. Pediatrics payer mix is so different than adult in that the majority of pediatric transplants happening in the US are funded by Medicaid. And those hospitals in particular, as pediatric trauma centers, they have a lower traditional Medicare ratio because their funding payer mix is different. And they've, over the years, really pushed and developed increased donation in their pediatric donors at their donor hospital. And so if they lose the donor count and they don't have traditional Medicare, for many of the pediatric hospitals, it's even a more crushing financial loss. In a way, they're not going to be able to have Medicaid increase payments for transplant. So that's why pediatric hospitals are uniquely impacted. It's related to their payer mix and the pediatric donor potential at often the same hospitals.
Thanks, Jen. We have another question from Barry Friedman. For all the reasons you discussed, DRCs and the effect on organ counts, can we not use the facility where brain death occurred? DCD would be a different process.
Barry, I'm not sure if you're talking about using the facility where brain death occurred as the facility that gets the organ count. But I think I addressed that a little bit earlier to say that I think our community needs to come together and really discuss that. The transplant centers who are reticent to transfer donors, those transplant centers that have opened donor care units in partnership with our OPO, and the freestanding donor hospitals. And I think we really need to sit down and talk about the cost of care delivery in donor care units, and where we may propose another model to CMS, as Alex had sort of alluded to.
Thanks, Jen. I think, interestingly enough, the last question is one that is very near and dear to both of your hearts, and is where can we learn about the patient advocacy and professional strategy so that the community can be activated?
Well, on the transplant center side, if you saw our first slide and the two communities of practice at AST that came together and continued this dialogue from a previous seminar that they were educating the community, and they are really weighing in and helping devise those conversations. So I'd certainly tell you to get engaged in your community of practice and your professional societies. Secondly, just to highlight one of the acronyms and organizations that Dara flashed up was the American Association of Kidney Patients. Their executive leader, Paul, was on the call and did a masterful job of advocating for the patient's voice as one of the stakeholders at the table to think through the impact on patients if this policy were to change.
And actually with that, I would just make a plug for the COPs, the DTO, the Donation Transplant Optimization COP, which is the one that I currently chair, is the newest COP of AST. And if these are the kinds of topics that are of interest to you, please join our COP. We're growing rapidly, and we're looking to add members from all aspects of transplantation and donation, especially looking at the interface and collaboration between donation and transplantation professionals to drive improvement, including financial alignment. So please join our COP. So I'm just to put it out there. And I think that we have slayed every question that has popped up. And so unless you have any further closing comments, Jennifer or Dara?
Well, thank you both. And Alex and I will continue through our our COPs to, share and communicate information on the hub and opportunities for us to continue to update everyone, particularly when a proposal comes out. We will make sure that everyone is well aware, and we will solicit your feedback, suggestions, and comments so that we can really shape the best solution for our community. I'll turn it back over to Andrea White at this time.
AST would like to thank Ms. Milton and Ms. Washburn, the Transplant Administration and Quality Management and Donation and Transplant Optimization Communities of Practice Controversy Conference Planning Committees, and all of our attendees for attending today's session. Please look for an email from Zoom in about a week directing you to a copy of the recording available free and on demand. Finally, please remember to complete the evaluation survey in Zoom and visit www.myast.org/education to learn more and register for our upcoming webinars. Thank you again for attending today's session.